never come out from behind a curtain before. It's really a new experience. I'm very honored to be here, and oh dear, I forgot this machine. Wait a minute, sorry. There. Oops, no, backwards, 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 backwards. And I want to start by acknowledging that the only reason I'm here is what my father used to tell me, which is an expert is somebody who crosses state lines, because you have really fine experts right here in Little Rock, Pat Casey, Eddie Ochoa, and Kathy Webb, all of whom have been really helpful to me in preparing this presentation. So any of them could tell you a lot of the same stuff I'm telling you, but I got on an airplane, so you have to listen to me. Okay. And Pat and Eddie and I are colleagues, along with people in Baltimore, Philadelphia, and Minneapolis in Children's HealthWatch, which collects data in 5 urban safety net hospitals on children under the age of 4. And we produce scientific research that we want it to be evidence-based and reviewed and done very carefully. We try very hard to be timely. I don't know if you know that most national statistics about things like infant mortality or food insecurity or you name it are usually 1 to 2 years out of date. So that when there is an acute policy change or economic change, by the time there's data about it, the people who made the change aren't around. And so there's very little accountability. And we try to be up to date within 6 months, which is one of the unusual things about our structure. And then we try to take the evidence, and in the naive belief that policymakers are swayed by facts, we try to share that evidence with our local and national leaders. We are particularly, it started out and still are very focused on food insecurity, which sounds like a very bland issue. Limited or uncertain availability of nutritionally adequate and safe foods, or limited or uncertain ability to acquire acceptable foods in socially acceptable ways. So when a child goes diving into a wastebasket where somebody has left a sandwich, that even if you let them eat that sandwich, that's not food security. And this sounds so bland, but this turns out to be the threshold for adverse health and developmental effects. You do not have to look like a international relief poster to be in jeopardy from poor nutrition. Why are we focused on kids birth to 4? Well, in this country, food insecurity is a pediatric disease. And if you have a child, your household is twice as likely to be hungry as if you don't. And it's about 1 in 5 of American children. It's higher than that in Arkansas. And the younger the child, the higher the risk. The best way to be poor in this country is to have a little child. This is what about in Arkansas? You've gone from being the absolute worst in child food insecurity to number 6, which is probably greatly to the credit of people in this room. There are about almost 200,000 of your future workforce is affected, which should scare you half to death when I start to talk about it. It's about 28% of the state's children. That's a lot of kids. And that's even though your average cost per meal is lower than the national average. So where I come from, food costs are really high. And that's one of the problems. But your food costs are actually relatively low. They're not low, but they're less that. And even so, you have this incredible rate of food insecurity. It is linked to multiple other hardships. It's linked to inability to adhere to medical recommendations. I live in the richest country in the world, and yet I'm forced to choose between milk and medicine, says the mother. Well, at least you'll be used to it by the time you get on Medicare. And this is really true. Well, why didn't you buy amoxicillin for the baby? Well, because the lights were going to be turned off, or he was hungry. Energy costs are a huge factor. I would think particularly in a state like this where where people are very dependent on pickups and automobiles to get anywhere. And so gas prices must have a huge impact. We saw hunger go up when our public transport went up. And there are really three heavily linked what I call material hardships. I'm sort of operating at the base of the Maslow pyramid. I'm all for people self-actualizing and being mindful, but first of all, they have to be safe, fed, warm, and housed. So you have food insecurity, housing insecurity, energy insecurity, and they all converge on the body of a baby. And again, the younger the child, the greater the vulnerability. Now, the most vulnerable children are also the most invisible children. They're certainly not marching around carrying placards. They're not even in school throwing spitballs at the teacher. And the fact is they are only visible, usually, to their families, maybe their child care providers and their health providers, which gives us a special responsibility for making a witness to their unmet needs because they're not visible. And the first 1,000 days of life, and this is world around, anyone who's done WHO work has seen this, are absolutely critical for brain growth and for the whole future health and developmental trajectory of the child. And this begins in the late prenatal period and extends to ages 2 and slightly above. Think of a baby. A baby's all head. And a baby's brain increases 2.5 times in the first year of life to 2/3 of the size it'll have as an adult. So that if we underfeed our babies, that affects the hardware, if you will, of their educational future long before the bell rings for kindergarten. Let's go back for a minute and talk about health impacts, particularly maternal child health, because although food insecurity is very bad for grown-ups too, this is where my major concern is, and also where you can get a huge bang for your buck. First of all, let's talk for a minute about food insecurity myths, of which there are a great many. Hunger isn't the problem, obesity is the problem. How often have you heard that one? In fact, although in children, obesity and food insecurity, particularly young children, is not linked. But in adolescent girls and adults, it is. And I think that's because children's stomachs are small, so they can't eat enough bad food to make themselves fat. They just eat enough to kill their appetites. But there's many reasons for this. One is the cyclical food deprivation and overeating, which is sort of like yo-yo dieting. Need to minimize per calorie cost. The first job is to make sure nobody in the family is crying from hunger. Lack of access to fruits and vegetables in low-income neighborhoods. Lack of opportunity for safe exercise. I don't know if this is a problem for you. It's a huge problem for us. I never tell people to go out with their kids and go for a walk because they'll say, well, doctor, you know, I live on such and such a street, and 2 blocks away and up the street, that's where that boy got killed. And we've had children killed, not by people who are aiming for the children, they're aiming for each other. But their aim is really bad. So people know it's bad to be fat, but it's worse to be dead. And so it's really hard to just tell people to just go out and go for a walk. There are people who are food insecure tend to have obesogenic practices in feeding children. When they have food, force, because they don't know if they're going to have it tomorrow. And also there's now been really clear correlations between stress and obesity. And in primates, there's what's called variable foraging demand, which is if you take non-human primates and by the end of the day, they get enough food, but they're never sure they're going to. It's not predictable, as opposed to another group who are getting food predictably, the same amount of food. The cortisol levels in the variable foraging demand, the food insecure, if you will, animals, are just off the charts. And again, from what we know about what cortisol does to brain development and stress, that's fairly alarming, as well as to obesity. Myth, ignorance is a problem. If you would just teach these women, it's always these and women, how to shop, cook, whatever, they would not be food insecure. And when people say, aren't they just ignorant, doctor, my response is not as ignorant as people are paying a whole lot of money to make them. If you look at these two urban billboards, the top is an absolutely exhausted physician talking about, take 5 fruits and vegetables. And then there's a nice, glamorous young girl encouraging you to go to McDonald's. I mean, now which one are you going to look at? And look at all the things that are directly advertised to children on television, on all kinds of internet sites, and on placement in movies. And if somebody's looking for, and the American Academy of Pediatrics goes absolutely ballistic on this, and they should. If anybody's looking for an interesting policy problem to work on, how to change our culture so we do not have direct advertising to children under the age of 12, which the rest of the world does not, it would be really interesting and would have a huge impact on obesity. Also, families, even well-informed families, can't afford to purchase healthy food. In much of the country, I would think, including Arkansas, you can get the same amount of calories of soda pop for 79 cents as for milk for $2.59. If you have $1.30 per meal per person, you can go out and do the same price check in your own stores. I'm sure the absolute numbers are different, but I bet the price differential is the same. And mothers know this. They say, how do you feed them without giving them harmful things? And again, I learned a wonderful research question from students at Santa Clara University, where I talked, and these were undergrads. They went around asking people, what would you buy if you had more money for food? And people didn't say Twinkies and soda pop. They said fruits and vegetables and meat. And I would suggest that you might try doing that here too. It's not that people don't want better food, often, but that it's simply out of reach. Myth, if only these women would breastfeed. Well, I come from a baby-friendly hospital, one of the few in the country, and we have lots of food insecurity. And breast milk is definitely the best milk world around, but it's only adequate for the first 6 months of life. And after that, the World Health Organization and everybody else says you need to complement it. This is a little homeless child who came in from a motel. He's a year old. He can't sit up alone. You see somebody's holding him up. And the family lived on 1 pizza a day, and mom was breastfeeding still, breastfeeding to a year, just like the doctor said. And he got the pizza crust and breast milk and came in horrendously malnourished. So just having these, quote, these women breastfeed does not prevent childhood hunger. So let's go from those myths to the facts from the medical literature. Food insecurity is associated with perinatal complications, including diabetes and hypertension, which are very costly. Food insecurity is associated with birth defects. This is anencephaly, the kid's missing part of their head and their brain. It's obviously lethal, but there are many more minor variants of it. Also congenital heart disease. For this I understand, this is a folate effect. The other, I don't understand the heart disease effect at all, but it's there. Very clearly, food insecurity increases the risk of a low birth weight baby. Now, this is not flaming malnutrition, right? This is people answering, 3 items out of that 18-item scale. And low birth weight is the major cause of infant mortality. Infant mortality is the fancy way of saying dead babies. And Arkansas is still 41st in the US for dead babies, kids who die before their first birthday. And this is a preventable condition. It's not just prenatal care, which is crucial, but also nutrition. Low birth weight in many places, and I bet if a kid gets to Arkansas Children's with low birth weight, most of them survive. They don't die, but they survive with handicap. And low birth weight increases developmental risk and lifetime health problems, including metabolic syndrome, but also obviously school difficulties. So this intergenerational cycle is extended. And many kids have less visible handicaps like ADHD or specific learning disabilities following low birth weight. Dr. Casey did most of the early research on this. What if you get a nice big fat baby out, a nice 7-pound baby? Is it okay then if they don't get enough to eat after that? Well, any parent will tell you no. Food insecurity increases health problems above and beyond the income level, including minor illnesses, hospitalization rates, which are very costly, iron deficiency anemia, which is a pathway to long-term developmental dysfunction, decreased bone mineral density. We see all these kids that we took care of, and then they wander in again to the ER at 5 or 6 with having broken their arms on the playground. And I didn't understand why until there was an article saying food insecure kids have decreased bone mineral density. Oh, duh. More susceptible to lead poisoning and very poor oral health. Sorry, back up for a minute. Those of you who've done work overseas, and I gather all the students have, right? Know that what kills kids, usually malnourished kids, is infection. And there is a vicious cycle of a child acquiring, in this country too, a perfectly ordinary illness, you know, what pediatricians call the crud, right? Throwing up, diarrhea, have a fever, bleh, and my kid and your kid and everybody's kid loses weight. But when a kid in a privileged home gets over the acute illness, they're ravenous, you feed them as much as they want, and they very quickly put themselves back on track. In most of the families that I serve, there's no extra. There's often not even enough, but there's surely no extra. And for example, if a kid throws up, you can't refeed them, right? There's no more. So the kid is left underweight, which impairs their particularly cell-mediated immunity and their IgA, more susceptible to the next infection, which they're less successful in fighting off, which causes them to lose more weight, and down the hill they go. And again, mercifully, most of our kids don't die, at least because we have good access to health care, as opposed to kids in, you know, the refugee camps in Syria who do die. But they are sick and sick and sick. Parents miss work. The kids get admitted to the hospital. They show up in the ER. So if you're really interested in saving healthcare costs, it's kind of simple. One of the things you need to do is give children a decent diet, consistently, not just every other week or when they get to school. And again, what should have been an ear infection is facial cellulitis in this child. Now, what about child development? I actually got into this by the back door because I'm a developmental pediatrician. Well, people know for their own kids that birth to 3 is critical. Doctor, what kind of mobile should I buy for my 2-day-old to make sure that he gets into University of Arkansas? But somehow they don't connect the dots to that, to what we are doing to the poorest Americans who are the youngest children. And then people say to me, if I ever get this idea across, well, if most of the brain growth is established by age 3, can we just stop our child nutrition programs at age 3? And I go, let's start over, okay? The actual size and structure of the brain is most vulnerable to nutritional insults early in development. But brain function is sensitive to the quality and quantity of the food that we consume throughout the lifespan. And the brain has huge energy consumption, and unlike the rest of our bodies, can't store energy. Okay, now you've never heard of anybody having a fat brain, right? And this is true for well-nourished adults. I don't know how many of you have done the SNAP challenge? Nobody? You have, good for you. Did you feel like this? Yeah, okay. This is a congressperson saying, my focus and coordination are not sharp. I have one thought at a time and I'm getting very confused, not to mention crabby. And any of you who've missed a couple of meals because you were working so hard or you fasted for your religion or on a really strict diet, you know, you feel headachy, sick to your stomach, trouble concentrating. And you can drag yourself around and not get fired. But you have no energy for discretionary activity, for rushing out and doing something new and interesting. And in children, learning is a discretionary activity. It happens when you're fed and warm and not feeling sick. So if you want your children to learn, they have to eat every day. No kidding. Young children in food insecure households, and again, we excluded the underweight kids from this because everybody knows that kids who are malnourished enough to be underweight are at developmental risk. But in our study, and we've published this with p-values and confidence intervals, all that good stuff, young children from food insecure households are 40% more likely to be at developmental risk controlling for background characteristics. And all the functions that allow children to succeed in a knowledge-based economy are at risk following early undernutrition. And so again, if you want to have a competitive workforce, you have to feed your children. Public policies and economic conditions are written on the bodies and brains of babies. If there's one take-home today, that's it. And can we fix it? Well, the answer is that depends, right? I saw a wonderful quote over in the Clinton Library today where Mr. G took me on a tour, which said, "There's nothing wrong with America that cannot be cured by what we have in America." And I think that's a total truth. But again, it's getting there is not so easy. Obviously, there are emergency fixes. The first one is you've got to give clinical care. This little boy is named Justice. He's 5 months old. He's maybe a pound over his birth weight. He was a nice full-term baby. His mom was breastfeeding. She lost her job, no maternity leave. Dad lost his job. He was a skilled drywaller. And they ended up homeless in the corner of a living room of some very unwelcoming relatives with this child and his older sister. And Mom lost her milk. The WIC program, which was being inflexible, said, well, you can't have new vouchers till next month because you've got your breastfeeding vouchers. And the mother kept taking the child back to not our clinic, but an outside clinic, saying, I want this baby to have his shots. And they'd look at the baby and say, he's sick, take him home. So finally she stomped in and she said, this child's going to get his shots. And they unwrapped the baby finally and put him on the scale and went, and of course rolled in to hospitalize him at 5 o'clock on a Friday afternoon. But it wasn't the mother. I mean, she tried feeding him dilute gruel, all the things that people in the developing world dilute oatmeal. The other emergency fixes is the Emergency Food Network, which is wonderful. Hospital food pharmacies. Food is really the cheapest medicine. And I walked all over your absolutely gorgeous children's hospital today, and you have so much space. I don't know, wow. And it's so pretty. And so much has gone into making it pretty. And maybe the next thing you might want to do is to think about a food pharmacy. We started it, and the reason I started it out of my own offices 20 years ago when a nutritionist came stomping into me and said, I'm tired of mothers bursting into tears when I tell them what their children have to eat. And I want to, get ourselves qualified for food from the Greater Boston Food Bank. I said, sure. Well, of course, in those days what we were getting was government surplus. We very quickly ran out of that. And so then I was running around to all the synagogues and churches and nursery schools in the neighborhood getting canned drives. And so, but then the security guards at the hospital started sending me people not in my clinic, pregnant ladies, and I said, I can't do this, okay? I mean, this is all I can do to feed the families in Grow Clinic. And you have to feed the whole family, not just the child. Everybody knows that. And then mercifully, our hospital, which was the city hospital, merged with the university hospital. And to their credit, the new administration, which came from the private sector, said, we need to do this. And they took it over. And they have professionalized and built this wonderful pantry, which, by the way, is a huge draw for philanthropy and publicity. And it's, in a fairly grungy building that is historical to the point that it's slightly falling down around your ears, and things like that. But it runs, and it runs very professionally. We write food prescriptions in the medical record, in the electronic medical record, and the family takes it down to the pantry. And it says, one diabetic, one baby, one a healthy adult, and one healthy 10-year-old. And that's how they decide what goes. And we're able to give people about 2 to 3 days worth of food. And good food. We do not, the other thing that drove the nutritionists crazy is spending an hour explaining to people, that Kool-Aid wasn't good food for babies, and then having them go to the local, church basement food pantry and get, tater tots and marshmallows and Kool-Aid. I mean, we might as well not have spent that hour talking. People don't look at what you say, they look at what you do. So if you want nutrition education to take, you've got to make people able to implement it. And we also have a demonstration kitchen across from the pantry where we show people how to do things. Now, those emergency fixes are crucial, just like emergency rooms are crucial, but that's not all that can be done. If you have a healthy system, you don't have to rely so much on emergency care. When you can't do anything else, you document. And one of my inspirations was the Dutch famine, and I'm sure most of the students don't remember anything about this. But after D-Day, the Germans were afraid that the Dutch were going to go over to the Allies, which they were right, and they blockaded half of Holland. So one half was starving, the other half was okay. These are the people in the starving section. And it was awful. The dikes burst, it was in the winter. They were down to like 600 calories per day per person. Well, they tried to do a little better by the pregnant women. The doctors and nurses were dying along with everybody else, but the ones who survived continued to do what they could do, and wasn't much. They had no medicine. But they had every mother come in, they weighed her, they followed her blood pressure. When the baby came, they weighed and measured the baby and registered the birth. That was basically all they could do, is they documented. But that work has turned out to be what has completely shaped our understanding of what intrauterine malnutrition does to babies. So they had no idea at the time. They just kept doing what they could do, which wasn't much. And some days I feel like, not that I'm starving, but that all I'm doing through Children's Health Watch is documenting, but you got to at least do that. And I would say, you know that the USDA food security scale is 18 items, and that's awfully long for a clinical setting, although we do it for research. But there's 2 items, the first 2, and if a family answers either or, that's about 97% of a young child, 97% sensitive to food insecurity. So that could go in your electronic medical record, in your needs assessment. And if it was in your medical record, you would then have your community needs assessment without, at least for food insecurity, without having to do much else, because you would be able to generate the statistics. Fixing hunger and hardship long-term is a political issue. That's what Jim McGovern always says, this is a political, hunger is a political problem. He's right. In this country, we have the food, we have the distribution networks. Nobody's, our food is not rotting in warehouses. Nobody's shooting at our trucks. Our trucks have gasoline. So all the challenges that people who are used to working overseas and trying to do food relief, we don't have. We could do this. It's just a matter of will. Our children's bodies and brains are suffering from hunger and hardship. The treatment is policy choices. We found that particularly after the ARA boost in SNAP, which has now gone away, that we could find health and developmental effects in young children. This is all on our website, so those of you who are into p-values, there you go. The SNAP prescription has been seriously diluted as of November 2013, because actually the money was taken to fund child nutrition, which is interesting. It went down from $1.63 per person per meal to $1.30. So you lost about a week of meals for a 10-year-old child. But no one's going to say, this week you don't eat, right? They just take what they have and stretch it, and the way to stretch it is to use bad food, basically. That will make people feel full, but is not nutrient dense. It is good medicine, even though the dose is too low, and there's been some data from before the increase that showed it was an effective medicine against food insecurity. You could qualify people for SNAP and for health insurance at the same time. Most of the documentation is the same. But that, again, is a matter of political will and joint programming. Also, I'm sure you know that in Arkansas, you're leaving millions of dollars on the table because you have an asset test. You can't have more than $2,000 in assets and get on SNAP, which means you can't have a car to get to work. That's your choice, right? Most states have done away with that. It also takes forever bureaucratically to verify what's the cost of this, car. And as you know, every dollar of SNAP generates about $170 in economic activity. So all that money for the economy of Arkansas is being left on the table. There's been a lot of snake oil about how much money this is going to save. In fact, it is probably going to just cost a lot of money in a different sector, which is healthcare, and this is the Pew Charitable Trust. who figured that just for adult diabetics, the cost of the SNAP cuts was going to be $15 billion, and that's not anything else, the children, the low birth weight. So now what do? We've lost the Farm Bill. We haven't lost as bad we might have. It could have been much worse. And there are other things we can do. Right now what's coming up next is the child nutrition reauthorization, and having robbed children of their dinner to pay for their breakfast and lunch, the next thing is the attack will turn to the child feeding programs, which come up in 2015, I guarantee it, since 60% of the proposed cuts or more from low-income programs. There are all these important child-focused programs in the child nutrition reauthorization. Of these, only SNAP and WIC are kitchen table programs, feed families in their homes. But the others are all crucial. Oops, sorry. WIC works, okay? Each dollar spent on WIC during pregnancy saves about $4 or more in perinatal costs. That's a chunk of change, right? We found that it's not just in the womb, but after the womb. The kids whose families got WIC, little kids compared to families who didn't, and it's only kids up to age 5 are eligible, were more likely to be health and at less developmental risk. And you can also facilitate access by co-locating WIC in hospitals and clinics, so people don't have to drive somewhere else, deal with a different set of hours and so on. You just say, go downstairs and talk to the WIC lady. In fact, in our hospital, the waiting room for WIC and the preventive food pantry, which serves everybody, not just children, is the same waiting room. So this is called our Nutrition Resource Center. Child and adult care feeding. We very poorly studied, but in our study we found that the kids had better health and growth and fewer hospitalizations. And given that they were in child care, where they're picking up the bug of the week, that's pretty striking. And you could improve it by streamlining paperwork and also bringing the reimbursement up to the real cost of the food, because many family providers are disincentivized from applying because A, it's so difficult, it's not online, and B, they're given these very useful, good, healthful guidelines, but they aren't given the money to realize them. Summer feeding, this is where Arkansas has had a triumph, both because Dr. Casey got it going in the hospital, but all over, I think it was. And you've had the largest increase in summer meals than in any state, which is phenomenal. I know there are huge challenges with implementing this in rural areas, and there's also been a randomized clinical trial, a gold standard, right? Showing that if you give families, the school-age kids, $60 extra per month per school-age child in SNAP, if they can't get to these sites, the risk of hunger goes down. So again, we have the American know-how. We can do this. It's just the will. School breakfast, particularly school breakfast in grab and go or in the classroom, and Arkansas has improved massively in this. But why are we bothering? I mean, every morning you get up and you read, some awful pronouncement or some awful vote. I guess am I being too partisan? But and you sort of think, well, why am I bothering? Why am I getting out of bed? But what fuels me is that we're talking real children. These are real babies, and they don't have to look like that, and they can get better. This is the same child, Justice, a few months later. And then people look at me and say, honey, don't you know there's a war on? And I smile at them sweetly and say, during World War II, Winston Churchill, who was a Tory, right? That would be like a Republican. While they were being bombed in London, so their homeland security problems were a good deal more scary even than ours. And remember, I come from Boston, and we had the Marathon bombing. Went on the airwaves and said, there is no finer investment for any community than putting milk into babies. So that's my motto. Thank you, and we even have a Twitter connection. I was told that the young people would appreciate that. And we also have a website. So I'm happy to take questions.
Thank you, Dr. Frank. Let's open it up for questions. And if you have a question, please raise your hand and we'll get the microphone to you. Does anyone, there's Pat, you're going to, I figured, wait a minute, hold on, wait for the microphone, Pat.
I just wondered, Debbie, with all the wonderful data we've collected over the many years, can we count many policy victories?
Well, the ARA boost, we saw this, improvement in the flattening of the rise in food insecurity until the value of the benefit was eroded by food costs, even before the rollback. We've certainly been able to show WIC. We've shown that people who get fuel assistance and housing assistance, their kids are less likely to be food insecure. So I think we do have an evidence base. The trouble is, I think your great opportunity here is we hope you're going to have an increase in minimum wage, right? So you'll have a lot of pre-data and then, we hope, post-data. And you may see health effects of that, because even the smaller increase will affect like 1 in 10 of the kids in Arkansas.
Anybody else with a question? I've got a question to ask you. What can children's hospitals do more or better than we're doing now on the hunger issue? What can hospitals do? And not just Boston's or Little Rock, but what can hospitals be doing, should be doing? Well,
first of all, they should connect the dots for lawmakers. When you go and say, we need to, if you're trying to get the bang for your buck in healthcare spending, you've got to make sure people are adequately nourished. I mean, that sounds like something your grandmother would tell you, right? And she would, and she was right. And secondly, you can make really clear in your actions that nutrition is part of healthcare, not just when somebody has a central line in and you're dripping all these things in, but that WIC is a health program. WIC belongs in a healthcare setting. Food is medicine. You can have a food pantry. There are, and you can certainly do, we have, our demonstration kitchen folks do, go walking through the waiting rooms doing cooking demonstrations. And we have a apple stand at our activity place. And some days we don't have any apples because no one donated apples. We have apples, we have, and then we have signs out saying, sorry, no apples today. But people, and then this business of making hospital summer feeding sites I thought was brilliant. We haven't done that. And Pat Casey and our Minneapolis colleague, Diana Cutts, have done it. I don't know if there's any place else that besides you too. Has there? No. But that's, that's groundbreaking. It's again, people don't look at what you say as much as what you do. And by engaging with the issue, you really make it clear both to the families you serve and to the policy leaders that this is a health issue.
Well, let's thank Dr. Frank for being here, and and thank every one of you all who are champions on this particular issue. It is something that is a national problem and certainly an issue in Arkansas. So thank you very much. Thank you all for coming.